Beginning. All right. And so we have begun. Nice to see everybody, most everybody. And this is where we ended talking about the limbic system and anatomically, particularly these structures, the hippocampus, the amygdaloid body, the mammillary bodies. I really think those are area, the cingulate gyrus, just to be familiar with those structures. There's not a lot to say about the reticular formation. It's really centrally placed along the brain stem, as you can see, with a variety of, and it goes all over. So when they talk again, when they talk about brain arousal, you'll see the illustration. So it filters out a lot of that stuff that it's like anything. Your ears do the same thing, like the sound that's going on back there, whether here or in the lab, something along those lines, background noise, it'll filter out that kind of stuff. Okay, and obviously, as you can see, there's a lot of things that impair it. So, uh, and that's the difficulty. So, and there's a lot of things that enhance it. And so, when we have a real severe injury in those areas, that's one of the ways that coma can demonstrate itself. Significant impairment. So, there are things. I mean, it's like shaking somebody, that kind of stimuli, pain, pressure, light. Somebody saying, my kids, we used to turn the lights on and open the blinds to get ready to go to school. I have no idea how they ever made it to school. They were the worst. Awful. Awful. And I mean, and now my daughter gets up at, to go, she's at the gym at 5:30, and my kid in the Navy, he's ridiculously early. My other one is here at work, works over with a company on Neville Island, like at 6. Go figure. They obviously changed. So moving on. So there's a lot of different things that they interact with. Okay. So there's a lot, and it sort of plays a role with things that we don't think about. As you become awake and alert, you have changes in blood supply, your heart becomes more active, your respiration. And it's an interesting illustration where visual, auditory, touch, pain, temperature, all of those types of things play a role in working its way up through this activating system, which you can see sort of lies here in the whole brain stem area in the midbrain, pons, and medulla oblongata, just basically to summarize it. And then once that stimuli occurs, then it directs us to the appropriate areas of the brain, and that really triggers our getting up. Everybody's a little bit different in how those things. This is not necessarily an area you're going to see in this particular PowerPoint. There's some important stuff, but after this, there's a lot of it's more sort of dovetails into physiology and things and memory and a little bit about brain waves, which I'll make a few comments about, but it's not my area of expertise. And so I hate to talk to you about something where I'm more or less reading it to you, and that really doesn't do a whole lot. So this kind of stuff, language, memory. I'll tell you a little bit about EEGs and brain waves, sleep and wake cycles and things like that. But really, this is about the only area that I think I have a fair amount to share with you about. Memory is so complex. And when you take psychology classes, do they delve into that to some extent? Memory is very, very complex to understand. Sometimes I'm lucky. I was blessed with a great memory. There's no two ways about it. I have semi-photographic memory. That was closer to very photographic when I was in school. So my dad did the same thing. Don't. That's the way it was. I remember obscure stuff. I'm always amazed when people. I think I told you I've gone to my 40th and 50th high school reunions. Don't look at me like that. Okay, so you're going to your second, or whatever it is, and I go, do you remember when we did this? They all look at me like, what are you talking about? Remember you wore this, and they're like, what are you talking about? Little data about that, just I don't know.
But you can't remember the post review time.
No, like that. That's because that's work. It's like remembering names other than yours. See, I remembered your name.
Yeah, but it's decent time.
I had to sort of mentally go through your handing in your things.
Do you remember it now without me giving you the hint?
Yes. KR. Is it a K or a C?
Okay.
Okay. Rendered me incapable. Making a pun out of your name. It's okay. I like you. We're alive. Brocas and Wernicke's we already dealt with. So it's more understand when just to review Broca's, you can understand, but they can't express it. It's not always spoken. That's a again. PowerPoint stage, I don't know how, however, the people who do these, why we don't subject them to review. Wernicke's, again, both spoken and written, they can speak, but again, it doesn't, it's almost like trying to guess the answer. Okay, so and I think the right side is sort of underestimated, but by and large, this emanates from the left side, and they just show you the same illustration. These different kinds of things, okay, in my way of thinking, we treat memory, and I've commented on it before. If you can compartmentalize things, if you can visualize images, that really helps you in a class like this. To be able to do those things, to look at those illustrations and somehow be able to place certain things. You don't obviously know all of it. So, and this is where, and I really think motor memory certainly is something that most of us have a fair amount of. But emotional memory, really, they're emotional things, and whatever profession you choose to do, when you either have mistakes or things of very great significance, those will stay cemented. Believe me. You'll think from a doctor perspective, when we see something, I had a very interesting case that was in my wife's uncle, who was a very severe diabetic, and he developed, probably from a wound we didn't even notice, necrotizing fasciitis, which is the flesh-eating bacteria. And it ended up in an amputation. And end of the story. To me, it looked like phlebitis, inflammation. I was a pretty good diagnostician. And he went to the guy who was the head of Montefiore's Department of Surgery, and referred him to at the time, whoever that physician was. He was very well known. And his name does escape me at this point. And I got a call from him in my office, and he goes, he said, if I hadn't seen that when I met my residency at Massachusetts General Hospital, I wouldn't have recognized it. Because he had seen it in the 30s or the 40s, because he was near retirement by that time. That's the kind of thing. When you see something like that, you don't forget it. And it's emotional, and a lot of times something you missed or something you didn't appreciate at the time. So we have short-term and long-term memory. It's so hard to discuss. I think, short-term memory is something I think you see it more in the context of Alzheimer's and in the context of aspects of dementia, where we begin to see the lacks of recognition, where people don't remember exactly what they did with it, that you and I would remember right away. That's something that certainly is a consistent finding. And all of these things, the idea of repetition and practice, what we call rote memorization, is not that efficient. Okay. If it serves you well for taking exams, fine. But you want to cement things in for long term. I mean, I don't do tests cumulative. Somebody will. If you're taking licensure exams, if you're taking medical board admission tests, they're cumulative by definition. Anything is fair game. So you need to be able to find a way to memorize things to keep it all in there. And that's true for doctors, for physician's assistants, for nurses, for whatever. They're all like that. I say it all the time. I view it as an intellectual challenge. To me, I'm not very good at sport competition. I'm very good at that type of competition. So that's where I like being able to do that. So whatever works for you is good. Okay. Association to me is really the key for a lot of these. All the different areas, no big deal. Not doing that. These are areas, and that's why we see the hippocampus implicated a lot in Alzheimer's, because we do see that memory loss. That's there. And there's different kinds of amnesia. Okay. And I don't want to go into them because I'm not going to ask you about them, whether it's current or behind. And then we get into the EEG. EEGs are at least noteworthy. We can do them. I mean, I don't know enough about them. That's why I don't. And they're very easy. You just put a couple of those leads like we do when we're going to do electrocardiograms on a willing subject and basically record the waves. And so I did this a while ago with a class 3 or 4 years ago when we first got to technology. And I said, and I wanted to play something very relaxing and like play some, loud, stimulating music. And so and people were wearing headphones and everything like that. And I said, and we did that first. I said, what are you going to play to try to relax people? And the one student who I still stay in touch with goes, I recorded one of your lectures. That'll put us to sleep. True story. I was a little offended by that. Like I can't sleep through it. Why should you? So this is understand why EEGs are relevant. Because if you're going into a medical field, brain dead is dead, legally speaking. I'm philosophic about that. I think as long as somebody there's still viability. I'm not into terminating people. That would never be something I would choose to do. That's why we have those pre-existing directives and things along those lines that are there. My mom was the one that was most proximal. I mean, she had everything specified out. She had done all that stuff legally before. She was very efficient in that regard. So we didn't have to concern ourselves, my sister and I, and so she died of Alzheimer's complications. But we use it a lot for sleep disorders and a lot for epilepsy, which are seizure disorders, a better way to describe them. We use it for these kinds of things to localize areas of damage, particularly for brain death from a medical legal. These are surface electrodes. There's nothing invasive about it. A lot. I think I don't know if it's better to do it directly on the skin. There's a cap that people can wear, and you usually see illustrations kind of like that. Where whether or not this is some type of headgear or if it's directly on, I do not know. Okay. But typically you try to get as many, and there's quite a few of them. And years ago, before we had greater advances in technology, they would come paper and they record on sheets of paper, the way all electrocardiograms were. And I remember sitting with a neurologist in one of the programs I was doing, and he'd be turning the pages and dictating, there's evidence of this and this, because he'd done it for so long. For somebody, this is evidence of a defect, and these are D waves or beta waves or alpha, all these different kinds of waves. So it's very, very interesting. And again, now we look at it for serial EEGs in the context of brain death. So patterns of activity and they're unique, they're a signature, and the way that they're grouped, alpha, beta, theta, and delta, and you'll see the differences that are there. Again, I'm just reading it to you, so whatever the different types that they are, different things that occur in deep sleep. So, and people with difficulty sleeping, it can be really very, very troublesome. A lot of times there's the respiratory aspect of those types of things. I never was a particularly good sleeper, still am not. Years ago, an old friend of mine said, if you get 8 hours of sleep, you're sleeping a third of your life. Kind of stayed with me. I'm just too interested. And this is what they look like, so I couldn't, For you guys, when you're listening to me, you're probably right here. So when we talk about seizure disorders, which is a better way to say it, spontaneous, irregular, very difficult to predict electrical discharges that overwhelm everything. And the classic ones, and they've changed the names a little bit. They used to call it grand mal. Were very, very bad, was the way it was. Now they're called tonic-clonic seizures because of basically what, the classic, jerky, uncontrollable, losing consciousness, and it's very stigmatizing. I always tell this anecdote. Because you may be someone will go down with a seizure, and people are always doing dumb things like trying to stick something in their mouth so they don't bite their tongue. If they bite their tongue, we'll fix it. If you start sticking your fingers in somebody's mouth who's seasoned, you could be losing some fingers. Okay, you don't want to do that. If they have this aura, the sense that it's coming, and it is there in a lot of people, either auditory or olfactory, or visual aura that comes upon them. That's the opportunity to get themselves like lying down and probably putting a tongue blade in. We used to keep a padded tongue blade on the wall. It was mandatory in your office for certification. So you have basically you have blade tongue depressors that were padded and taped up, so you could stick that in there. Now, I fortunately never had one, but my first wife and I. My first wife was an RN with a BSN, and we were walking in the Carnegie in a museum, and there was a group of mentally disabled citizens, young people who were looking at some of the art, in a large group, and all of a sudden, we're walking, and she sees this gal goes down, and she races in there, and we always did that, and all she did was she cradled her head, because in that shaking on a hard floor, that's when you really can hurt yourself. And I asked her, and that's when she told me about the tongue blade and not sticking your fingers in. That's what they taught in nursing school. Hold their head. The problem is they lose bowel and bladder control. It could be very, very stigmatizing, very embarrassing, you know, for a lot of folks. And so that I can remember that scene, like, to this day, and that was probably right around the time we got married in 1978. Yes, sir.
You're supposed to put like someone who's having an epileptic seizure, just put them on their side.
That would be a good idea if you could. If you could, anything that would limit their head whacking against the surface. So as long as you could get under them or have blankets or a pillow or something soft, a cushion from a chair.
It's not because of like vomit.
Well, yeah, absolutely, that too. The problem with somebody vomiting, and it could certainly happen, is you see that more, and that was always a great concern post-operatively, because a lot of the medications in the old days made people vomit, and they it's called aspiration pneumonia. So it's like a geyser that comes up and it goes in, and without reflexes that are fully functional, it'll go down in your lungs and it's just filled with awful stuff. So that usually a lot of bacteria. I mean, so aspiration pneumonias are preferred to get used to, but that would be absolutely on the side. So I mean that would, I think it's more about the head first. Anytime you see somebody who's down, you would like to get them on their side because of the aspiration thing, whatever the source was.
I heard that's how a lot of people OD is from aspiration, from aspiration.
It's awful. We saw too many of those. We had, when I was a resident in Philadelphia, we had a large alcohol detox unit and we had a large drug detox unit. We're in the inner city, we're in North Philly, in a rough area, difficult area, and high crime area. And that's so many people with problems like that. So, I mean, we too often. I mean, if you're, and we had availability of things like Narcan, which is much more commonly used today. But it's very sad, very different. I mean, they had so much stuff. I had, for any of you going into a medical field, watch out for your prescription pad. I had a guy who was a patient, and I was sure he was a drug seeker. Like a lot of doctors, I'd leave my prescription pad in a drawer, and my secretary was there, whoever was at the desk, one of the people working for me. And so he was checking out, somebody came with distracted her, and he was able to grab my prescription pad. All of a sudden, I'm having a meeting up on Route 8 with a guy from the drug unit, from the state drug unit, because they knew it wasn't my prescription, because they had my own signatures on it. And they finally got the guy. I didn't have to testify because basically what happens, these guys will plead guilty to a lesser charge and implicate somebody else in the trouble. It gives you an idea about it. It's real. You gotta be so careful. It's writing for 100 Percocets. So that's where they picked him up at some pharmacy up in the North Hills with a script for 100 Percocets, and the cop got him. Unbelievable. So epilepsy or seizure disorders, this is another mistake. Even though that anecdote involved someone who was mentally challenged, this was not necessarily commonly associated with it. A percentage of our population, okay, different factors are there, anything. So it can be something that you unfortunately have. In children, they get what we used to call petit mal. small bad things, but they were like, now they call them absence seizures, where we'd be talking and all of a sudden the child would, and then resume right where they left off after X amount of time. So the aura, here the absence seizures, you see it more in children, the tonic clonic, very, very severe. And this, again, all of those things, biting a tongue. Oh, they're going to swallow. No, they're not going to swallow their tongue. You'll deal with it once the seizure's over. Okay. And it's very interesting. I'm not that familiar with the treatments anymore. We don't necessarily understand anticonvulsive drugs, but as you will learn shortly, when we start talking about trigeminal neuralgia, when we start looking at the cranial nerves very soon, you will find, because the nervous systems are sort of our next anatomical unit, from a laboratory perspective, you'll find that they use anti-seizure medicines for nervous disorders without understanding necessarily how they work. It's really just a work thing. Because my wife has one, and I'll give you the whole chapter and verse about that, a very severe condition called trigeminal neuralgia, and she has to take anywhere between 3 and 6 pills every day of something called carbamazepine. So, and then this is the idea of consciousness, and fine, whatever it is, I'll buy it. Yeah. Another term for somebody faints is called syncope. A lot of things can lead to that. Typically, people can be overheated. Certain people, and older folks, they have a problem with what's called orthostatic hypotension. That means changing position too rapidly. So you always tell, and I do it myself. So if I get up to go to the bathroom in the middle of the night, okay, I will sit up in bed and I'll stop there. And when I go to standing, I'll hold on to a nightstand or a desk, even for a brief second, just because you don't want to start doing a tumble. And my mom did the same thing, even when she was living by herself with a walker, to get around, you'd sit, stop. That, because the sensors don't function as well that keep the blood flow consistently to the head. And it's accentuated by blood pressure medicines, of which I take too. So I'm a little more careful with that. Many of you think I'm just dizzy anyway. And then emotional problems, overheating, and coma would be extended. And then all the idea, whatever the current legal aspects are, I do not know what they are. And the whole thing with eye movements and dreaming and stuff, I don't know anything about. So I'm not going to ask you. I'm sure there's videos you can watch about this that you might find interesting. And different rhythms that are involved and chemicals that wake you up and things like that. You got all that stuff. So I'm looking at the importance of sleep. Nah, not that important. I'm another one, and I don't remember dreams. I have them. My wife's always telling me about hers. She goes, "What about yours?" I said, "I don't remember." Sir.
It says it declines with age, that you don't need as much sleep, but I feel like all the old people I work with, they get mad if you mess up their sleep schedule.
They do get it because they're very much scheduled. It appears that way, but you don't need as much. If I get 3 or 4 hours of sleep, which is probably what I had last night, so football game was lousy. So I was reading for a couple of hours. Maybe I went to bed 11:30 or 12, like 4 o'clock in the morning. I believe that's true. How old are your folks in like a nursing home environment?
Yeah. They just sleep all the time.
The physical plant shutting down. That's kind of, if you didn't know the way Alzheimer's explained to me, you think of it like growth and development. When the baby is able to walk, swallow, eat, Alzheimer's is the reverse. So a lot of what we see is not so much mental impairment, it's losing those capabilities. They can't swallow, so you have to use purees rather than liquids or solids are probably. I have a lot of experience with older folks. Because most of my practice life was 2/3 of it were people 65, 70. Okay. My wife's the same way. Where do you work?
Just an assisted living.
Assisted living facility. Yeah, we did my wife, before she got her LPN, was a nurse's aide, and she worked there for more than 10 years in both those capacities in Cranberry, which is now part of this. Now it's part of UPMC, called Cranberry Place. There. So we came to that, and my first wife, interesting enough, ran a nursing home. On evening, she was a night and evening and weekend supervisor over in Wilkinsburg. The old Wilkins house. I think now it's gone into some type of assisted living facilities when they revamped it over the years. So we did a lot of that. And there's some oddball things. Narcolepsy, very famously, it's one of the few true diagnoses that require amphetamines. These people who literally go into to just start to sleep out of nowhere. And so there's interesting things about that, all the insomnia, and I'm not going to get into it. This is important. So of all the things I'm telling you about, this is the ones you have to remember. The meninges or meninges, however you want to pronounce it, they are the coverings of the central nervous system. They're extraordinarily important. You're going to see several illustrations, so you're going to have to know about them both from a test perspective and from an identifying perspective when we get to that. So they protect all of those things: blood vessels, venous sinuses, everything that is associated with your brain and spinal cord is surrounded, although not identically so. And what's within them in a certain area is cerebrospinal fluid. So cerebrospinal fluid, again, is similar to the plasma of the bloodstream. It's not identical. There's variations in chemicals. It doesn't have the same type of, if you find white blood cells in there, that's a problem. Now you're probably dealing with some kind of meningitis, either viral or bacterial. If you had a choice, you'd rather have viral. Bacterial is bad. That's immediately life-threatening. And yes, they are part when we do the brain. And so I think we may actually be Monday. I have brains to dissect. So I think we're going to do cranial nerves and do a brain dissection Monday, and then have the bones and the joints, bones, so you guys can review it. Sound like fun? Nothing like dissecting a brain. Just to say. So you're going to see that and what reminded me of that was you're going to actually see, I try to get the ones that have the dura attached. The dura is the outer, the thick layer from the word. It's very, very strong and tough, the derivative of the word durable. So it's called the dura mater. And mater originally was mother, but we just call it matter. So this was the hard mother, arachnoid, because it looked like a spider web in the interior, and pia for soft or delicate. And the pia mater is directly adherent to the brain and spinal cord. It's very difficult to discern. Just like when we do a heart, the epicardium is a liner that's adherent to it. And it's so thin and delicate, you really can't lift it up and dissect it off in a dead specimen. The arachnoid is where the fluid is found in the area between these two layers. And we call it the subarachnoid space. And the area between the dura and the arachnoid has a variety of blood vessels. So we often see bleeds both in subarachnoid and subdural. So when you hear about someone with a subdural hematoma from striking their head or a fight or an altercation of some type or a traumatic injury, typically the blood accumulates in there and blood has nowhere to go in a closed space, so it presses on the brain and you have to relieve the fluid pressure from it. And you see this a classic illustration when we're looking at the brain dura, and it's different than the spinal cord. Okay, you have the skin the periosteum, and the bone. Okay, fine. Now the dura has two layers. It has a layer adherent to the bone called the periosteal layer, and then underneath it, it has the actual meningeal layer. And these are the dividers, and the name we give to them is falx, F-A-L-X. And you will see them. And areas where they separate form sinuses. Sinuses are really flattened areas with venous blood. So the word sinus has a lot of meanings. In bone, we have sinuses typically around the nose, the perinasal sinuses, ethmoid, sphenoid, maxillary, and frontal. And you have sinuses back here in the mastoid process. The temporal bone sort of help resonation with voice and, our fluid and air storage areas. But what we see in these sinuses, as you can see, are little outpouchings that really play a vital role because the cerebrospinal fluid is in here. These are called arachnoid granulations. So they're outpouchings of the arachnoid. You can see the little spider web kind of appearance, which we really don't see in the dissection. It's not nearly as visible as in an actual viable brain. And these are covered, okay, with specialized cells that you'll learn about in the physiology term called ependymal cells that help to kind of finalize the cerebrospinal fluid and also help to circulate it to a certain extent. And so these are like, think of them as like little overflow valves. You make about, in the areas where we make cerebrospinal fluid, about a half a liter, about a pint a day, and you siphon off cerebrospinal fluid this way into these sinuses, and it joins the rest of the blood returning to the heart and effectively is recycled. So if you have too much being produced and not enough being siphoned off, it can cause a problem, or the other way around. More often it's too much than not. So you can see the divided areas, which are several, in between the periosteal and meningeal layers. The actual meningeal layers are in contact more or less directly with the brain. There's a space, and within that space, frequently you can find blood vessels. And then as we look further, you can find other sinus-like structures. Here's the arachnoid, and you can see vessels in the arachnoid. So you can have subdural bleeds and subarachnoid bleeds, but where the fluid is in the subarachnoid space that are there. And so here again is that falx cerebri sort of dividing the right and left sections of the brain. So the singular is meninx for meninges or meningeal areas. 2 layers of fibrous connective tissue, periosteal and meningeal. Okay. Sinuses forming. The sinuses eventually collect and effectively form the jugular veins. So usually the names are the same for an artery and a vein, radial artery or radial vein. There's a couple areas where it's not. In the heart, you have coronary arteries, cardiac veins. Going to the brain, your major blood supply is the carotid artery, but there's no carotid veins. They are the jugular. And the jugular veins coming together along with the circulation from the upper extremity form a very famous superior vena cava. So that drains effectively your head, neck, and upper extremity. So inwardly in every area, so these dividers are, again, the name falx. They're thickened. The one you're seeing there, long ways. The one along the vermis, and you'll see this as long as we have the specimens with the meninges intact, and then even forming a little tent over the cerebellum. It's neat. And now you can see some of the names, and this is more circulation, superior sagittal sinus. That's there. So you'll be able to see those. The straight sinus is sort of in that cleft between the cerebellum and the cerebral lobes that are there. Up and personal that way. The arachnoid, because of those spider web type of extensions, cerebrospinal fluid, large blood vessels, and again, to me, they're like little siphon points or little overflow valves that permit reabsorption back into the bloodstream. And then the right adherent, and again, you really can't see it, is the pia mater. Very, very delicate. Tiny blood vessels. So what's meningitis? Inflammation of it. The big problem with a lot of meningitis, it becomes encephalitis. Meningitis inflames the linings. Eventually, they'll inflame the brain itself. That's the distinction between meningitis and encephalitis. The one, again, that is immediately life-threatening is bacterial meningitis. That's why we do spinal taps for fever of unknown origin. When we don't have a ready diagnosis, that's a test. You have a very, very high fever because there's no wiggle room. That's the big problem. You don't, if it's bacterial meningitis and you don't make that diagnosis right away, the patient is either going to die or be severely damaged over time. And it's the only diagnostic test for it. Viral meningitis is probably a little more common and you have a little more time. So it is a bit scary because it can happen. So, and the old story, if it happens to me or to someone in my family, so my daughter, I'm going to tell you, is probably about, I guess she's around early 20s, 24, 25. I'm just recalling the time frame. And I was like on standby because she was in the hospital in case there was a problem with my granddaughter at the time in school, who would have been, middle school or high school. Uh, Apparently, the feeling was that so maybe the granddaughter's a little younger. The feeling was that it was probably herpetic, and the doctors felt that it was as though she was going to get a cold sore, and rather than it coming out of the nerve and demonstrating like on her lip or in her cheek, it went up. And the reason they were confident of that, what fixed it, if you will, what treated it successfully was it was sort of like Valtrex, but they're called acyclovirs. They're the medications of choice and the most effective of the antiviral medicines that we have. So she responded to that, even though after doing an initial course of treatment, they sent her home and she started to develop the classic stiff neck, headache, low-grade fever. So they put her back in for 4 more days or so. So it's really very, very scary. So that's the distinction that's there. So we observe microbes in, and so particularly if you see bacteria or white blood cells associated with bacteria, big trouble. So, and really effectively your brain is floating with fluid on the interior and the ventricles and fluid on the exterior. So it's doubly cushioned. So it's buoyant. It reduces the weight, as you can see, substantially. So it doesn't sink down. And when someone has cerebrospinal fluid hypotension, that's exactly what happens. Their brain sinks into the foramen magnum. And again, and from a bad spinal tap for a back injury, my wife's best friend suffered this. And she never recovered from it. It's always affected her with headaches and medication. It effectively disabled her. It altered her physically. I mean, you went from this very trim, attractive, to being unfortunately very, very heavy, and really altered her weight and altered her life substantially. I mean, it's just amazing. And that was from a spinal tap that didn't work. They tried what's called a blood patch. So they you basically take your own blood and inject it in there so that the platelets and the clotting factors will be successful. My first wife had one of these. The blood patch actually worked a little bit better. She also had a lumbar puncture for back problems. Just to give you an idea. So composed of watery solution, partly plasma, less protein, different ions that are there. In certain areas in the ventricles, the choroid plexes are where it is effectively siphoned off or removed from the plasma and then altered and manufactured in such a way. And again, the ependymal cells are there. Ependymal cells are ciliated, so they move. They're able to generate the circulation. This will show you the circulation. Okay. Ion pumps to control it. The cilia move it. And again, so if you think of it this way, a volume of about 150 milliliters replaced every 8 hours. You get an idea about what it is. So 450, 500 milliliters, about half a liter, about a pint of cerebrospinal. And the circulation is neat. Where it's in red, in the lateral, third, and fourth ventricles, it's produced. Now, it doesn't just stay within the ventricles. In the fourth ventricle, there are 2 lateral apertures and 1 median aperture that allow the fluid to go out, surround the brain on the exterior, and also it goes down the spinal cord and goes all the way down to the bottom of the spinal cord. So it's completely surrounded and floating. And they go through the series of things if you want to read it. That's what it looks like. That's the capillary nest. These are the ependymal cells. You can see that they're ciliated. Okay, and this is what happens when there's something obstructs it. Okay, increased pressure, and because in newborns, like periodic, you'll see something called hydrocephalus. I think they have a picture of it in here, and you have to use some kind of a shunt to remove the fluid, which are effective, and thankfully, for the most part, if it's addressed sufficiently, so in adults, it's much more of a problem. Much more of a problem. So shunts are what are used. That's classic hydrocephalus in newborn. And all of this is about the blood-brain barrier. Other than in the area of the hypothalamus, where it's weakest, and that's where we can sense chemical and ionic levels in the bloodstream, sugar and electrolyte levels that are there. Okay, there's a and we look at it much more closely in the physiology portion, which is chapter 11 in this particular textbook. You have an abundance of tight junctions that make it very much watertight, and it's surrounded by what are called astrocytes, a particular connective tissue cell that are in contact with the nerve. So everything has to be fat soluble or non-water soluble to be able to really impact the brain. So tight junctions and astrocytes really maintain that barrier. So substances move, lipid soluble, blood gases, oxygen, carbon dioxide, lipid soluble agents. Why? Specific medicines have to be compatible with this. Okay. Glucose, amino acids, and other ions are very much unspecific. Your brain only runs on glucose. So all sugars eventually make glucose. Okay, once they're into simple carbohydrates, so they run on glucose that are there. And they're just showing you a difference between most capillaries. Here, you have a lot of tight junctions, you don't have the little cleft, and you have these astrocytes surrounded. And the astrocytic feet, they are the ones that come in contact with the nerve. So it's almost like materials flow through the membranes, through the feet, and then into the nerve directly and back. Okay? So as you can see, there's a lot of other nuances that the area where it's not the vomiting center and hypothalamus, because that's where it will trigger vomiting protectively or be able to detect chemical composition. It's there. I don't want to give this short. I'll come back with concussions and contusions on Monday, and we'll start there. And then Monday will be very much into the spinal cord class. Have fun. Goodbye. So happy to see you and happy to be done. Happier.